All right, guys, we are now going to be doing your circulation and perfusion. All right, so circulation and perfusion is chapter 37 in your F.A. Davis textbook. And we know that circulation is the movement of blood around the body. And then perfusion is the body that is circulating and delivering the oxygen to our organs and our tissues. We know that without oxygen, those tissues and organs will die. So these are just some key terms from your circulation and perfusion chapters. Then we have our chapter objectives. And we're going to start with the structures of the heart. And we're going to have a visualization of the cardiac cycle on the next slide. And in a few slides, we'll be looking at that electrical conduction. So when we talk about the cardiac cycle, this is a simultaneous contractions of the two atria, followed by a fraction of a second later by the two ventricles. And then our electrical conduction is completely within the heart. And it's going to be explained more in the next slides. So this is that visual representation of your cardiac cycle. So we have diastole, and diastole is when the heart is at rest and it's going to be filling up with the blood. This is when we hear our S2 or our dub. Then systole is your action phase of pushing everything out of the heart, which is your lub or your S1. This image, notice how the atrium contracts right before the ventricles. So we have an atrial systole, and then we have the ventricular systole. This is the video that HTTPS and all of that will take you to watch that if you want to view that on your own time. This is the basic electrical structure of the heart. So we have our SA node, and the SA node is where it starts, and your SA node is going to be 60 to 100. And the SA node goes to the AV node, and your AV node is about 40 to 60. And this is when we have the contraction of that atrium. And this little Bachman's bundle is what gets that side of the atrium to contract. Your SA node, all of your electricity in your heart is intrinsic, meaning that it occurs just within the heart. So if we give somebody a paralytic, it does not affect the electrical activity in the heart. Our SA node is considered that pacemaker, and it has that rate of 60 to 100. And if something happens to that, then the AV node will pick up. And the AV node is at 40 to 60. After it goes to the AV node, it's going to go down the bundle of His, and it's going to go into your right and left bundle branches. And those bundle branches and Purkinje fibers and all that's going to help with your ventricular. When you hear about a patient having some type of cardiac arrhythmia, it's going to be something that's occurring here in that electrical system. The next components of the heart that we'll look at are going to be our valves. So I know this slide's a little bit busy, but the reason it is because this area over here is where we listen on our chest to hear our heart valves. So your all pigs eat too much is your location of where we listen. All is your aortic, and that's going to be on that second intercostal space right of your sternum. And then up here is the actual aortic valve in the heart. And then we go to our pigs, which is our pulmonic, which is on that left sternal border across from the aortic, which is right here. And if you look up here, you can see how your aortic valve and your pulmonic valve are right next to one another. Next point that we have when we're listening is our herbs. Now we know herbs point is not a valve. It's just a really good location to hear all of your heart tones, your S1 and your S2 at one time. The next one we have is 2, which is our tricuspid, which is found in our fourth intercostal. at that left sternal border. And then when we go over here, we can see how that's here in our heart. We know that this particular valve is on the right side of the heart, and it separates your right atrium from your right ventricle. The last valve we have is the much, which is mitral. And your mitral is that only valve that's going to be at that mid-clavicular line. So we're going to go into that clavicle area all the way down, and then that's our mitral valve right there. The mitral valve sits in between your left atrium and your left ventricle. So what do valves do? Valves prevent blood from flowing back into the heart. Our commonly heard terms when we talk about valves is valve stenosis and valve regurgitation. So valve regurgitation looks like this. And this is when we're going to have a backflow or leakage. It occurs when blood backflows through the valve instead of being pushed forward through the heart or into the arteries. Blood leaks back into the chamber. Regurgitation is usually due to a prolapse, when the flaps of the valve do not close tightly, but instead they kind of bulge under pressure. These leaky valves are often referred to as incompetent valves. And then we have stenosis. So stenosis, while regurgitation refers to the valves that do not close properly, stenosis refers to valves that do not fully open or do not open properly. They result in a narrowing of the path of blood flow, causing the heart to work harder and reduce the body's supply of oxygen. Stenosis may result because of valves flaps thicken, stiffen, or fuse together due to age or damage, or because the valves were malformed before birth. Stenosis can occur as a result from rheumatic fever, a childhood illness that's now really rare in the United States. It can also be from a complication of untreated strep throat or scarlet fever. You'll learn about more valves when you get to MedSearch 2. So the next we have our structure of the cardiovascular system. So we know that we have a systemic and our pulmonary blood vessels. So this is the image of the systemic, and these are, our pulses that we learned about when we were doing our, assessment and vital signs in lab. And then this is the pulmonary capillary network that we learned about in our oxygenation. And we know that our arteries are going to have thick elastic walls that allows them to stretch during cardiac contractions, so systole, and recoil when the heart relaxes, which is diastole. We have arterioles, which are small branches of arteries, and all arteries have that pulse to them. And then arteries will lead to the arterioles, which will lead to our capillaries. And capillaries are going to be that microscopic vessel that are about 1 cell thick, and they're going to facilitate that exchange of gas, nutrients, and waste between the tissue cells and the blood. After we do this exchange, our capillaries will enter into our veins and our venules. So these are thin, muscular, but non-elastic walls that can collapse very easily. These walls contract or relax in response to feedback from our sympathetic nervous system. When blood volume is low, the veins contract to provide a smaller space for smaller blood volume. When blood volume is high, our veins relax and enlarge to accommodate the increased volume of blood. We can have thick venous system, and that's kind of our holding tank for our fluctuation of blood volume. Veins have valves, and the valves help prevent the backflow of our blood. So again, we have our heart, which leads to our blood vessels that carries our red blood cells. Red blood cells are made up of hemoglobin and hematocrit. Your hemoglobin is going to be your oxygen carrier. Arteries have that oxygenated blood, so the hemoglobin that still has that high oxygen concentrate. Once it passes through that capillary bed and it makes that gas exchange, that hemoglobin becomes deoxygenated as it goes through your veins to carry that blood back to your heart and back to your lungs to then be reoxygenated. The next structure that we're going to talk about is our coronary arteries. So your coronary arteries fill during diastole. So when your heart's resting, they fill. And this is how your heart gets oxygen and blood supply. We have two main coronary arteries. There's the left main coronary arteries, and then there's the right coronary artery. Your right coronary artery feeds blood to that right side of the heart, and therefore it feeds blood to your conduction pathways. So a blockage here can affect the electrical activity of the heart. Your left main coronary artery, if it gets blocked up high, is considered the widowmaker, because if it will blow it, basically the entire left side of the heart will die from no blood flow. So when we talk about somebody having an MI or a heart attack, especially if it is a acute ST elevated MI, that's because we're having an issue in here and a blockage in here. We can also have coronary artery disease or your sclerosis, which is the buildup of plaque. So that's these arteries that end up getting plaque builds up in it. And when that plaque gets built up in it, you don't get as much blood flow. And that limited blood flow can give us heart attacks, or it can give us just ischemia, which is the slow death. And our ischemic times, we're going to have pain. And if we have too much ischemia, that's when we have a non-ST-MI. And you'll learn about all of that when you get to acute med-surg 2. So remember, the AV node is not the pacemaker of the heart. The AV node is that 40 to 60 rate. The pacemaker of heart is the SA node, and the SA node has a rate of about 60 to 100. But how do we regulate these rates, right? So when we talk about the heart beats intrinsically, it does its own thing. However, it can be affected by our sympathetic and our parasympathetic. So we have our autonomic nervous system, which is part of our overall nervous system that controls our automatic functions of our body. And those are the functions that we need for the body to survive. These processes, we don't even need to think about. Our brain just manages them, whether we're awake or asleep. And our autonomic nervous system breaks down into 3 divisions, and each of it kind of has its own job. So the first one is our sympathetic nervous system. And this system activates the body's processes that help us in times of stress or danger. So this is going to be the body's flight or fight response. Your sympathetic nervous system is going to cause your heart rate to increase. It's going to cause your respirations to increase. And then we have our parasympathetic nervous system. And this is going to be the opposite of the sympathetic nervous system. This is your rest and digest. So this is going to help things slow down and relax. And then the last one is your enteric nervous system. And this is part of how our body digests. So it's not really talked about too much regarding your cardiac cycle. So when we talk about the autonomic nervous system and the parasympathetic and the sympathetic fibers, your sympathetic and your parasympathetic systems kind of create a good balancing act. And that sympathetic nervous system activates your body's processes, whereas that parasympathetic kind of slows things down. So we need that balance to keep our well-being and to keep our ongoing survival. So our heart rate regulates itself intrinsically, but during that sympathetic stress, that anxiety, that flight or fight, you're going to speed up. And we can't live in that constant state of speed up, because that would release those catecholamines, and we'll just have all of those extra issues that happen behind that. So then our parasympathetic will slow it down. We also have the brain centers, and these integrate feedback from our baroreceptors and our chemoreceptors in our body that are going to help regulate our cardiac function and our blood vessel. So the vasomotor center controls the sympathetic stimulation of the heart and the vascular system. And then we have the cardioinhibitory center, which controls the parasympathetic slowing of the heart rate. So our baroreceptors are located in the walls of our heart and blood vessels, and they're very sensitive to pressure changes. So the aortic arch and the coronary artery baroreceptors are particularly important in our regulation of our heart rate and our vascular tone. When baroreceptors sense a drop in pressure, they're going to send a message to the brain to kind of stimulate that sympathetic nervous system to increase the heart rate and induce that vasoconstriction. So that's how, if we start to hemorrhage or we lose our blood, we'll have a drop in pressure. And the first thing we're going to notice is that increase in heart rate, because that's your body's sympathetic nervous system being triggered by the baroreceptors, because we have that loss in pressure. Just like if we have somebody who's going very fast on their own and we tell them to bear down, by them bearing down, we're putting increased pressure on those baroreceptors, and that should kick in that parasympathetic to help things relax. Our vascular system has our chemoreceptors located in it, and those are in the aortic arch as well as in the carotid arteries. These are going to be sensitive to the changes in your blood pH, your oxygen level, and your carbon dioxide. Remember our ABG values. That's where these guys come into play with the cardiac system. So their main function is going to be to regulate ventilation, but they can also send information to the vasomotor center in a response to a lack of oxygen, right? Because we know that if the heart's your pump. So if these chemoreceptors say, hey, we don't have enough blood here, they're going to activate that sympathetic system to say, you need to pump things around quicker. We need to speed up that circulation so that that oxygen starts to get carried in more places. So there's a lot of different processes that kind of regulate your cardiac function here. And then we have our developmental stages, right, that can contribute to it. So infants have to transition from outside the uterus into, becoming a fetus to an actual infant. And that whole process, we can have congenital heart defects, and things like that. Then our preschoolers, right, their body systems need to mature and they need to adapt, and they're learning stresses and they're learning changes, and that's going to include the heart and the circulatory system. However, children as young as school age sometimes begin those bad social habits like tobacco use, and that stuff can have long-term adverse effects. Our adolescents, developmentally, they're at little risk for heart or circulatory disorders if it's not already been identified. However, again, we can look at smoking, we can look at poor dietary habits, childhood obesity, and all of that can impact their cardiac function. Our young adults and middle adults, now is when that sedentary lifestyle, lack of aerobics, and tobacco use is really going to compound into true cardiovascular disorders. Crack cocaine and methamphetamines can lead to sudden cardiac failure. However, sometimes cocaine use leads to really good collateral circulation, which is when the vessels that feed the blood heart, those coronary arteries, those guys actually build extras of those. And then again, in that young and middle adults, if we have a familial history for cardiac disease, you again have that extra risk. Then for our older adults, we have a lower exercise tolerance now. They're going to need more rest after exercise. And these guys are also going to be more prone to orthostatic hypotension. Some environmental factors. So again, when that sympathetic nervous system starts to fight off because we're having a stress response, we're going to release catecholamines. The more catecholamines we have, we're going to have an increased heart rate. We're going to be changing our contractility. We're going to have some vasoconstriction going on, and we're going to have an increased risk for blood clots at this point. That sustained stimulation of that sympathetic nervous system could lead to cardiovascular disease. It can also create a chronically suppressed immune and inflammatory response, which places our patients at an increased risk for infection. Allergic reactions and air quality. An allergen is that hypersensitivity or over response to an antigen. Inflammatory substances released during an allergic response, like your histamine and protease, can cause cardiovascular events from blood vessels dilating. We have eosinophils and neutrophils that are attached to the reaction site. We can have local tissues that are damaged by the protease. Capillaries are going to become more permeable, resulting in a fluid leakage into tissue. And then we can have our smooth muscles that are going to contract. When we talk about altitude, remember before, the higher we go, the less oxygen we have. That can lead to our altitude sickness, which can thereby change our red blood cells, and we're going to need an increased production of them because our body's going to want to circulate more oxygen around, so it's going to need to circle more blood around. And then our heat and cold. So heat generally causes a vasodilation, which increases cardiac output and oxygenation. However, heat also increases our metabolism. As a result, people are naturally more sedentary in hot weather. Cold slows cell metabolism, reducing oxygen demand. It also causes vasoconstriction and slow heart rate. Induced hypothermia is used in surgical procedures. As another example, victims of cold water drowning have been reviewed after long periods, in part because of the reduced O2 demand associated with hypothermia. They have better outcomes. And then we also now do cold therapy after a code because we know that that helps our improvements. More factors that can influence your cardiac function. So of course, our lifestyle, right? Pregnancy, we have the mother's blood volume that increases. So we're going to have an increased oxygen demand. Our nutrition, if we have the low fat, low cholesterol, low sodium diet, that's that heart healthy diet. We need proteins to prevent anemia, and that's going to help reduce our blood oxygen carrying capacity. And our obese patients, which would be anybody that has a BMI above 30, this can cause multiple health problems, which can affect your heart and your circulation. It increases your risk of developing that atherosclerosis, which is those coronary artery disease, and hypertension. It also changes the workload of the heart. Exercise is going to improve your blood circulation and the delivery of oxygen to tissue and cells. Tobacco use, we know, is that major risk factor for that atherosclerosis, which is that fatty buildup in the arteries, hypertension, the decrease in your HDLs, which is your good cholesterol. And then substance abuse, large amounts of alcohol depresses your respiratory, cardiac, and vasomotor centers of the brain. Chronic alcohol can cause fatty infiltration of the heart muscle, thrombosis, so clots in the coronary arteries. It can lead to an enlarged heart and dysrhythmias, all which can ultimately lead to heart failure. And then we have illicit drugs. So our stimulants, our hallucinogens, our cannabinoids, all of these have an adverse effect on your cardiac system. Medications. So we know that many medications can change our heart rate and reduce the force that our heart contracts with. They can reduce our cardiac output and impair our tissue oxygenation. The two that I've listed here are commonly used cardiovascular depressants. So the first is going to be your beta blockers, and the beta blockers are used therapeutically to reduce the workload of the heart and to control abnormal heart rhythms. These drugs are going to block the beta-1 receptors and thereby decrease the heart rate and decrease the strength that the myocardial has to contract. Our calcium channel blockers block the flow of calcium into the cells of the heart and the blood vessels. This decreases the blood pressure and the strength of the myocardial contraction, slows the heart rate, and dilates the arteries of the heart. Our cardiovascular abnormalities. So if you hear them talking about heart failure, the heart becomes an ineffective pump and is unable to meet the body's demands. Blood is oxygenated when it passes through the lungs, but is not well circulated to the organs. We have an impaired circulation that's going to lead to either systemic heart, systemic edema, which would be your right-sided heart failure, or pulmonary edema, which would be your left-sided heart failure. Or you can have both, where you're going to have systemic and pulmonary edema. Cardiomyopathy is when the muscle of the heart is enlarged, and because it's enlarged, it has an impaired ability to contract. Cardiac ischemia is going to be the oxygen requirements of the heart are unmet. So prolonged ischemia is going to lead to your myocardial infarction, or you might just have a little bit of pain due to the ischemia. And either way, this is going to be that inadequate oxygenation. Coronary artery disease is a condition in which that plaque builds up inside those coronary arteries. Plaque's going to narrow the arteries, reducing the blood flow to the muscle and make it more likely that we're going to have clots that are going to form and block those arteries. Dysrhythmias are going to be alterations in that heart rate or rhythm. So they're going to lower your cardiac output and decrease your tissue oxygenation. And then we can have all of our different heart valve abnormalities. These are going to create turbulent flow, leading to decreased cardiac output. It's going to compromise your tissue oxygenation. You're typically going to hear some type of murmur with this when you listen with your stethoscope. It's most commonly affected in the mitral valve and the aortic valve. Those are your left-sided valves. And remember that your valves can be either stenosed or giving regurg. We can have our peripheral vascular abnormalities. So this is going to be that impaired blood flow to and from our organs and tissues. Our arterial abnormalities are going to disrupt the flow of our oxygenated blood to our tissues. When we have arterial abnormalities, we're usually going to have pallor, we're going to have pain, we're going to have a weak or an absent pulse, we're going to have poor capillary refill, cool skin, and tissue dysfunction. If we have a venous abnormality, that's going to be a disruption of the blood returning to the heart. These patients are going to have edema. They could have brown discoloration in skin, and they can have some tissue dysfunction, so like a stasis ulcer. If we have an oxygen transport abnormality, such as anemia, so we don't have enough red blood cells, enough hemoglobin to carry the oxygen around, or carbon monoxide. Carbon monoxide is a colorless, odorless gas produced by our fuels. And when it's inhaled, carbon monoxide binds to the hemoglobin at the oxygen receptor, and it doesn't let hemoglobin drop the oxygen off at the capillary beds. So our nursing process for our perfusion, we always start with our assessment, right? So we want to assess for pain. And the reason that we want to assess for pain is depending on how the pain is, kind of gives you a good idea of how significant the cardiac issue might be. If you're somebody that has cardiac pain, even at rest, that means that even when the heart is at its least working capacity, it's not meeting its oxygen demands. If we have pain with activity, then we know that when we put an increased demand on the heart, that it's no longer able to oxygenate. So one patient is, obviously going to be more unstable, and that would be the one that's having pain at rest. We're going to want to know the location, the duration, the frequency, if it radiates. A lot of times your MIs are going to have referred pain. So that's going to be we know that they're having a heart attack. So we expect them to have pain in the left side of their chest, but they might have jaw pain. So that's that referred pain that we learned about. We're going to want to assess their fatigue level, right? Are they fatigued all the time? Are they fatigued when they have to get up and do something? Do they have a lack of endurance? Fatigue is a common symptom of different oxygenation problems. However, it can also occur when we're anemic or if we have heart failure. Shortness of breath, we know that signs of hypoxia can be associated with cardiovascular disease and anemia, as well as with respiratory problems. We also want to know if their pain provokes dyspnea or anxiety. And we also want to check their peripheral circulation. So if we notice that maybe somebody doesn't have a good pulse, we need to check. We need to see and assess all of their pulses, right? Are all of their pulses really weak, or is it just their right wrist? How's their right wrist compared to their left wrist, right? Are their radials the same? What's the color of the skin, distal further from the pulse? So is my radial pulse kind of weak, but my hand's still really perfused and pink and warm? Or is my hand starting to feel cool? Another thing that we might want to assess when we're looking at arterial is how's our hair distribution, right? Because if we start to have that shiny skin and that lack of hair, that could definitely be something related to a peripheral circulation issue, especially looking at like the arterial side of things. We want to check for edema, right? Because if I have a really swollen brachial area due to an IV infiltrating, well, then that swollen fluid could then impede my circulation down to my hand. So we would also want to check for stuff like that. The different blood tests that we can do, right, for testing for oxygenation. Well, we can do a pulse ox, right? That's just that capillary. We can do capnography, which is going to give us our CO2 level, or we could just do an ABG, which is going to be that arterial blood gas. They also do VBGs. The difference between your ABG and your VBG, right, is that your arterial blood is going to be prior to that gas exchange, and that VBG, that venous blood gas, is going to be after that gas exchange. So you would expect your venous to have a lower oxygen level and a higher carbon dioxide level versus your arterial, which hasn't dropped its oxygen off yet or picked up its extra carbon dioxide. So we can see how those would be different. We could also do a CRP. CRP is something that checks our inflammation. We could also do a lipid panel. Your lipid panel is going to check your LDLs and your HDLs, as well as your triglycerides. And we can do glucose levels, troponin level you sometimes hear about, especially if we're thinking that the patient is having some type of myocardial infarction. When that tissue damage happens to that cardiac muscle, it releases that cardiac marker. It's an enzyme. And if we capture that, then we can say that somebody's maybe having an MI, even though they might not have a complete occlusion of one of those coronary arteries. However, patients who have significant cardiac issues like cardiomyopathy, where that heart's really big and boggy, sometimes those patients always have troponin levels. We can also do a BNP. So this is a hormone produced by your heart. The BNP is released in a response to the change in pressure inside the heart. These changes can be related to heart failure and other cardiac problems. The level tends to trend up as things get worse inside. And then as the heart failure is stabilized, they tend to trend back down. We can also do cardiac monitoring, right? And that's going to be, those heart monitors where we're actually looking at our cardiac rhythms. We can have rhythms like a sinus rhythm, a sinus tach. You can have your supraventricular tachycardias, which are super fast and regular. You can have your junctional rhythms, which come from lower electrical activities. And then we can have ventricular rhythms, which can be lethal and deadly, and tons of different rhythms in between here. Our cardiac placement of our monitoring. This is just one example of how you could place your cardiac monitors. You would have to do these based on your organization's package. And then this is how the electrical activity goes through the heart and how it appears on your cardiac tracings. So our P wave represents the firing of the SA node and that conduction of impulse through the atria. So this, from your SA node to your AV node, is your P wave. And then your QRS complex represents your ventricular depolarization and leads to your ventricular contraction. So this is shaded purple. And all of this is your ventricular depolarization, and then it contracts, which means it gets tight and it pushes the blood out. And then your T wave, which is here, this is your T wave. So this is your QRS, and then we come up into our T. And your T wave represents the return of your ventricles to an electrical resting state so that they could be simulated again. Now, remember, when we talk about our T waves, if we have a peak T wave, meaning that it's really high like that R wave, our P waves get peaked when we have too much potassium. If we have a flattened T wave, that's because we don't have enough potassium. When they talk about an elevated T wave, an elevated T wave means that it's coming off of this isotonic line, this iso line. So this natural line, elevated T wave is going to be one of these little boxes elevated higher than that. And that's when somebody's having a ST segment, an STMI. And that just means one of those arteries that feeds blood by the heart is completely blocked off. And that's why you're seeing that. And we'll learn more about that when we get into Med-Surg 1. So when we talk about our different types of nursing diagnosis or concepts, after you've collected all of your data, if you're doing just a concept, your concepts are easy. Everybody's a perfusion, right? Somehow, whether it's an electrical activity, whether it's a coronary artery, whether it's a valve issue, whether your heart's too fat and boggy, no matter what, you're not perfusing properly. If you're doing your nursing diagnoses, well, then it gets tricky, right? Is it a tissue perfusion? Is it a cardiac output? Are we repaired with shock? Are we not perfusing just our peripheries? Are we not perfusing our heart? So when we get into our nursing diagnoses, it can get tricky, but our concept's super easy. We just fall under perfusion. So our different types of interventions are going to be dependent on what's going on. So if I am really anxious and I'm shooting off my sympathetic nervous system, and that's causing my heart rate to go fast, and because my heart rate's going so fast, I'm not able to adequately perfuse it. So I'm getting intermittent chest pain, right? Best thing that you're going to do for me is manage my anxiety. If we're looking at something that's more a promotion of circulation, it could be issues with blood being backflow, or, if you're having pulmonary edema because you're having left-sided heart failure, you might have to give your patient diuretics. If you're having somebody who's having right-sided failure, and because their right side's failing, it's backing up and they're getting edema in their legs, we might want to elevate their legs above their heart. We might want to put compression stockings on them. We might want to encourage ambulation. If they're in bed rest, we're going to want to do range of motion while they're in bed. If we're worried about clot formation, right? So if our blood is kind of stasis, so it's just kind of pooling in our legs, because if we have really bad peripheral vascular venous return and our veins are just kind of getting bigger because the blood's more pooling down there, we cannot be at an increased risk for a blood clot. So if your patient has a blood clot in their leg, this is going to be a deep vein thrombosis, known as a DVT. They're going to have pain, they're going to have redness, and they're going to have swelling of their calf. We have to be cautious with these patients because depending on where it is in their calf, it can easily break off and travel and become a pulmonary embolism, which would be a clot in their lung, or it can become a stroke, which would just be a clot in their brain. It could also break off and become a clot that lodges in one of their coronary arteries, giving them an MI. So if we have somebody who has a DVT, a lot of times we have to put them on bed rest. We do not want to massage that calf, because if we massage that calf, we can break that clot off. And we're going to have to put them on types of medications that's going to help break that clot up and stop more blood from sticking together. Other interventions we could do would be administering medications. So again, our beta blockers to kind of slow things down. We could do a vasodilator to kind of open things up. We can do a diuretic to help reduce some of that edema, whether it's edema in the lungs, which would be your pulmonary edema from your left-sided heart failure, or edema in your legs from your right-sided heart failure. And then, of course, we can always do CPR if the heart completely stops pumping, right? And CPR, we have to do Annie, are you okay? We're going to assess for signs of cardiac. So do they have a pulse? Are they breathing? If not, we need to call the code. If they are not breathing, but they have a pulse, we know that if we do not breathe for them, they're going to go into cardiac arrest. If you have somebody who's in cardiac arrest because of a blocked airway, typically opening the airway and starting to breathe for them again will reverse their cardiac arrest. A little bit more on cardiac arrest. Again, remember, we're going to assess the patient. If they have no pulse and no respirations, we're going to activate that emergency response or your alarm system, which is going to call that code blue in that hospital setting. When we do our compressions, we want to do at least 100 compressions a minute. When we breathe for our patient, we usually breathe one breath about every 8 to 10 seconds, which is about 10 to 12 respirations a minute. We want to make sure that we're doing high quality CPR. We want to limit our amount of interruptions. If you're doing CPR out in the public and you don't have your handy dandy bag mal vask on you, you can just do hands only CPR, because we know that most people that go into cardiac arrest in the public area, it's typically because of a heart issue. So their oxygenation should be good. And if we can just circulate that oxygenated blood around their body, it's preventing ischemia of all those cells. So hands only CPR is still better than no CPR at all. We just need to make sure that we push hard and push fast in the center of the chest, and that somebody is calling 911 to get advanced services there. And that is the end of your cardiac lecture.